Okay, so I was asked to give a talk about doing lumbar decompressions. I'm going to talk a little bit about just decompressions in general. A little bit of talk, just briefly over decompression techniques in cervical spine as well, but just go over kind of how I do it, why I do it the way I do it, some of the tips and pearls. And this is an interactive discussion, so I'd love it if you guys want to chime in on things that you think or know or have experience with the way you guys do decompressions as well, so that we have some discussion on some of the techniques and what we're seeing. But I'll go through kind of my techniques and why I do what I do, and radiographic evaluations in the operating room to kind of help the fellows as they go forward and learn how to do this, how and why we do what we do. So what are our indications? You guys good? Good.
Yeah, there's an echo from someone. Go ahead.
All right. So, why are we doing decompression surgery in the first place? We're unpinched and pinched nerves. The symptomatic neural impingement comes from degenerative changes, spinal stenosis, the most common, synovial cyst. My MRI in the slide shows a large synovial cyst at L4-5. We get neural impingement from our instability processes and deformity processes, metastasis in the lumbar spine. You can have acute structural change or trauma, so you can have a fracture that causes acute neural compression that requires decompression. Disc herniations are probably the most common thing we see. Then we have the other variants such as infection and neoplasm that can create spinal neurologic compression that requires decompression. So we need techniques to be able to do that safely and effectively without creating instability as a part of the process. So what are our techniques? I think the principles for decompression in the spine are similar whether you're doing a laminectomy, a laminotomy, or foraminotomy. You're basically, regardless of where you're going, you've got to observe the same techniques within the anatomic variances you're working to achieve neurologic decompression without creating instability. So obviously, the majority of these procedures are done posteriorly in the spine to achieve decompression of neural elements. There are anatomic and biomechanical differences in the areas, so it dictates what you can and can't do. So obviously, in the cervical spine and thoracic spine, the spinal cord is present, so that's not something you can retract. So if you have certain pathologies, decompressing those requires some thought in terms of how you're going to do that, and oftentimes we are going to do more of an anterior-based decompression to achieve cord decompression, but there is still a role for posterior decompressions in both the cervical and thoracic spine, but the most common place we're doing it is in the lumbar spine. The pathology dictates the technique, in my opinion. So in other words, what you have to decompress will dictate what you do. The most classic lumbar decompression technique is a classic laminectomy, where the back arch of the spine is removed, and so the diagram shows essentially what is effectively removed. And so you can see it's a midline corridor. The spinous process is removed. You're trying to preserve as much of the facet joint as possible. And essentially within the diagram, you're going pedicle to pedicle through a central opening in the back arch of the spine, removing the lamina, the spinous process, and a portion of the medial facet joints in order to achieve decompression. Most commonly, we're going to do laminectomy still in a congenitally narrow canal, when you have to do decompression for tumor and wide decompression. You have somebody that comes in with a very large disc herniation or some other causation for a cauda equina compression, where you really have to achieve effective decompression of the entire neural canal and all the neural elements. Upper lumbar and the thoracolumbar junction quite commonly require laminectomy versus laminotomies, simply because it's very difficult to access through a midline approach to get under the spinous process and leave it intact, decompress the neural elements at that level. So there's still a role for doing laminectomy, although you guys will see myself and the other surgeons doing decompressions that we're doing a lot more laminotomy procedures, and we'll talk about that and the technique and why we do that. So a laminotomy, that's a unilateral generally approach. I use the diagram showing the tubes or a tubular type approach, but it doesn't really matter whether you're using a tube or a different retractor. The principles remain the same. You're going to be able to approach the spine usually through a unilateral approach. And by angling your approach, you will either do a unilateral decompression, or you can do bilateral decompression through a unilateral approach, leaving the spinous process and the lamina intact on the opposite side. And so my diagrams there show the different angles and the different apertures that you would require to be able to see or visualize the neural canal at the different angles to do the work. I do laminotomies for almost all of my spinal stenosis now, almost always for disc herniations and synovial cysts. I will oftentimes do bilateral versions, so I'll put that angular approach from both sides to decompress central stenosis bilaterally, leaving the spinous process intact if possible and the part of the lamina intact. And I try to preserve as much of the facets as I can to preserve stability. The surgical approach, we'll talk about principles. Let's get this right. I have Greg's patient in the bottom left corner. No, I'm kidding, Greg. Sorry. But the key thing to getting a decompression right is to get your patient position.
Coxectomy practice.
What's that?
My coxectomy practice.
Right, yeah, there's if you're going to decompress that, well, that's probably the right position. That procedure. I was going through images and I'm like, oh my God, I got to put that in there. Just like the gal who just was having a bad day and didn't check her dryer load. So anyway, obviously a Wilson frame, as you can see in the upper picture on the left, places the lumbar spine in deflection. It essentially opens up the interlaminar space so that theoretically you can access the spinal canal, potentially with removing less bone for access. I think that's most common if you're going to be doing a soft tissue procedure such as a disc herniation operation where you just need access to get the disc material out. I think it's less relevant for patients with spinal stenosis where the bony decompression, we're going to talk about that in detail, but where the bony decompression is required really to achieve relief of the pathology that you're treating. You can do decompression in a standard Hall frame on the right. It works fine. But one of the other key things is to make sure that the patient's abdomen is adequately decompressed during the surgery. One of the things that I have seen is that if you place a sheet within the Wilson frame or the Hall frame and it creates compression of the abdominal structures, you're going to get a ton of back bleeding. And you can take an operation that has essentially no blood loss and turn it into a 500 cc blood loss case because there's so much intra-abdominal pressure that you're getting a ton of back bleeding into the paraspinous muscles and more importantly, the epidural space, which then significantly diminishes your ability to see what you're doing and adequately decompress the neural elements that you're trying to decompress. And it can turn your operation into a failure simply because you cannot see what you're doing at any time during the operative position. You want to make sure your light's in the right position when you start because you've oftentimes got to bring your microscope in. So if you don't have that set up ahead of time, you're not going to be able to access the opening you've created, especially since we're doing these really small incisions now for doing decompressions. You want to make sure your light's in the right spot and you want to make sure your microscope is working before you start. It's very disheartening to bring the microscope in the field and it is not set up correctly to do the work. So these are all the things you have to set up and think about before you even start. The other thing that I'm a stickler about is localizing my level. So I've got some representative radiographs. This is the same patient, synovial cyst. I'm doing a decompression at L4-5. So the first C-arm picture on the left is my spinal needle. I have not made a skin incision. I basically brought the C-arm in. I placed the spinal needle where I think the L4-5 interlaminar space is going to be roughly. I drop the spinal needle down. Do not aim the spinal needle in the midline towards the interlaminar space where you could potentially have a dural injury before you even start because I've seen the needle push all the way to the disc space, right through the interlaminar space. And so you are now transdural. And you now have a CSF leak before you even start your decompression, which is not a good way to start the day or the case. So again, I aim my spinal needle from the midline towards the facet joint so that I minimize the risk of that. And then I try and localize initially to plan my skin incision with the spinal needle in place. Once I make my skin incision, I will recheck my position once my retractor is in position. And it doesn't matter what retractor you're using. This is a modified Taylor. It's about 18 millimeters wide, so it fits into about a 2 centimeter incision, which is about the same as you would need if you're going to use a tube. So whether or not you're using a Taylor or a tubular-based system with dilators, the principle is the same. You're going to identify and make sure that the place that you're working is where you want to work. The retractor position in this X-ray on the right is telling you you're at the disc's interspace or just below it at the L4-5 level. If you are above that, let's say this retractor was at the pedicle of L4 and I'm looking at the interlaminar space, I'm actually looking at the L3-4 interlaminar space if I'm at the pedicle of 4. So the retractor, ideally the interlaminar space is going to be at or just below the disc you want to work at. So it's very disheartening when a patient wakes up, their symptoms are no better, you get their postoperative scan and you've done the wrong level. So I recheck my imaging as many times as I need to make sure that I've got the right level that I'm operating on. This is especially important when you're doing small incisions, essentially minimally invasive surgery, because we're really dependent on our imaging to localize our levels. And that's true whether we're doing perc screws, but really important when you're doing decompression where you're not actually targeting the pedicles at the levels you're working at to instrument them. So that's one of the things that I do routinely, is to recheck if I need to multiple times on my radiograph to make sure I'm in the right spot doing the right level. Once you're there, the visualization is the exposure where you're working. So again, open a procedure using your cob. You're going to identify the spinous process on the side you're working on. You're going to make sure that you have good subperiosteal dissection and exposure so you can see the bone, you can see the medial facet, you can see the lamina both above and below in the interlaminar space. This is my working field. So I create it very carefully, whether or not you use an open retractor or a tubular-based retractor. The need to visualize your bony anatomy so that you can then visualize your soft tissue anatomy is very key. So you want to control the bleeding on the way in, you want to have good lighting with your headlight, and then ultimately your microscope, and you want to make sure that your retractor is in a stable position so you don't lose that field throughout the operative procedure, which will, one, slow you down, and two, you put you at risk of complication or neurologic injury if your retractor is not stably positioned. So the first thing I do is, once I've got my inner space visualized, I got to figure out how much bone do I need to take. And I don't think there's a right answer for how much bone you remove, because everybody's pathology is a little bit different. So if you're doing a very, very tight stenosis, or you're going to take out a large synovial cyst, or a very large disc herniation that is extruded cephalad or caudad, you're going to have to take more bone in order to access the pathology. So you got to be able to take enough bone so you can visualize the pathology, access the pathology. You need to decompress adequately, and you want to minimize your risk of complications during that. So in other words, if you try to make a really small window to do your work and you can't adequately either visualize or retract the neural elements to do your work, you're just simply placing the patient at a higher risk of a neurologic injury or complication. You also have to have enough access to be able to control the bleeding. So that's kind of the key for how much bone do you remove. The answer is it just depends on what you're doing. You need, I continue to remove enough bone so that I can adequately see what I'm doing. One of the principles I will use is I want to detach my ligamentum flavum. We're going to talk a little bit about that in another slide. Ligamentum flavum, proximal and distal within my interlaminar space so that I can remove it. Generally, I'll try and take it out at block if I can, but I want to be able to access it, both proximal, cephalad and caudad, to be able to take it out when I'm doing part of my decompressive work to access the nerves, so I can retract them if I'm doing a discectomy, or just decompress the neural elements underneath with the procedure. So it's a process of removing enough bone to see is the bottom line. How do I do it? I will thank Bob for his introduction to me of the diamond burr. It has revolutionized my operative practice. So this burr is essentially a little round grinding wheel, but it cauterizes as it cuts. It greatly decreases the amount of bleeding in the operative field. So for bony removal, because it's essentially cauterizing the bone as it's removing it, essentially improves your visualization throughout the operation. What are the issues with a diamond burr? Well, it cauterizes as it cuts. So it creates a ton of heat. So you have to cool it down. So you have to irrigate it routinely. You have to irrigate the bone dust and the smoke that comes from that process routinely throughout the operative field. If you're not careful, and I maintain my ligamentum in place until the very end of my bony decompression to help protect the underlying neural structures in the dura. But I've seen thermal durotomies from this when the burr tip gets really hot and then touches the dura, it just burns a little round hole in it. And then you've got a essentially very difficult to repair dural tear. If you set it down while it's hot on the drapes, it'll burn a hole right through the drape, and now it's no longer sterile. And then you have a lot of smoke that can develop in the operative field, and so it reduces your visualization. So your assistant has to be very diligent about keeping in the field with you to get the smoke out of the way so you can see. One of the technique issues with using a diamond burr is you got to use more pressure. It's not a very aggressive cutter. You're using it as a grinding wheel, so you got to put more pressure at the tip, which means that you've got to be able to control that pressure and control where the tip of the burr is going. And it does, as the fellows will tell you as they first learn to do it, it takes some getting used to in terms of how hard you actually have to push the burr into the bone to get it to remove the bone safely, effectively, and in the direction you want. I always tell the fellows, and I always remind myself of this, this is a tool. All the burrs that we use are essentially tools to essentially remove the bone in a linear fashion. It's not a drill, so we shouldn't be drilling holes with this thing. We should be effectively scraping along the edges of the bone so we can widen our area of visualization with a fairly broad sweep of the burr tip to keep the pressure even and try and dissipate the heat as much as possible. And then we've all seen the fact that when you're doing these procedures with any burr, whether it's the diamond or a standard cutting burr, there's a ton of bone debris and we end up having to wait on our suction. The suction maybe is the most important tool in the operating room at some points, because without it, you can't see anything. There are other, obviously I put some pictures of some other ways to remove bone. So the cutting burr is something else you can do. It requires less pressure. It can be directional. So the neurotip, which is the third within that field, one's a coarse diamond burr there, but the neuro precision tip allows you to do, it's essentially a side cutting burr. So basically you can use these cutting burrs to be directional as well. And but the issue with the cutting burr as opposed to a diamond burr is going to get more bleeding. And if you get those cutting fluted edges up against the dura, now you're going to get a different type of dural injury where you can get a actual tear. It's a high speed, high energy tear. So it can be quite significant, and neurologic structures are more risk theoretically with this type of burr. So you got to be careful with any of the burrs that we use. Actually, any of the cutting tools we use, whether it's Kerrison punch or the burrs, anything that we're using to compress the nerves can actually injure the nerves as well. So the final tool that I will use, other than just standard curettes, which I don't really remove too much bone with those, but I use a Kerrison punch. I will, that's a hand controlled, although they do have pneumatic powered ones. That's something I want to be able to feel and use to control. It's designed to, has a foot on it to protect the underlying neural structures. And there are issues with that. And the principles are you got to have a safe plane to work. So I always try and create the plane for the foot to fit in within the epidural space or within the space between the bone and the ligament to create a place for that foot to fit. And so basically we have different sizes of Kerrisons because the spaces are different. So that's why we have different sizes for that. And if you have really hard bone, it can be very difficult to punch through. The drill may be, or the burr may be a better solution for that. Hard bone, if you're going to try and do the entire work through a Kerrison, can make your hand very tired, which is why I think some guys invented the pneumatic punch. But I think you have less control with a powered device like this. There's a lot of feel associated with using the Kerrison, in my opinion. So that's one of the, but these are all tools to get the job done, to get the bony removal done. Once it's done, once you've created your laminotomy or laminectomy field, whether you use the same principles, whether you're doing a full laminectomy or a laminotomy, the difference is for this, you're not removing the spinous process, you're trying to preserve that so the muscles have a place to attach. But once I've done my bony work, now I'm going to separate my ligament. I try and identify the superior and inferior ligament attachments to the undersurface of the lamina if possible. And I will usually separate them off superiorly and inferiorly with a curette. I got to make sure with my lateral recess decompression in the lumbar spine that I've identified my superior articular process and my inferior articular process. I've removed a part of those medially with the burr and with the Kerrison. I want to make sure that I've got a separation plane between the bony edge and the ligament. And then I'm going to basically, I use a technique where I'm going to slide my Woodson elevator in my opening of the above or below, depending on what's easiest to come in, to get it underneath the ligament, place the Woodson tip between the ligament and the underlying dura. And then I will create a linear incision as is shown in the field there. And then I will gently manipulate the ligamentum, usually if I can, and block, because I've detached it superiorly and inferiorly. I will then gently pull it away from the dura, separate off the soft tissue and the adventitial tissue that's underneath the ligamentum towards the dura. I'll sweep that off and then get the ligament out of my field so now I can look at my neural structures. So that's how I do it. What are some tips for removing the ligament and facet capsule? And the facet capsule essentially is a part of the ligament in most cases. So again, remove enough of the lamina and the facet to see the tip top of the superior articular process. So when I'm doing my lateral recess, I want to be able to take enough of the inferior lamina. Let's say I'm doing 4-5. I'm going to take enough of the inferior lamina of L4 to be able to see the top of the superior articular process. so that I can remove it medially and adequately decompress the whole lateral recess out to the level of the medial pedicle wall of the inferior vertebra where I'm working. I try and take my decompression out to that medial pedicle wall, so I've adequately decompressed the lateral recess and the traversing nerve. Beware of a calcified ligament. So if you have a calcified ligament, as in the CT, your true area of the space to put your curette and divide your plane is actually not going to be readily palpated or visualized, because you're going to see bone more medial than you normally would. So, and again, this calcified ligament, and that's in this picture in the CT, is actually right up against the dura. So you can actually use that plane if you can identify it. But the key thing is to understand that you may have calcification within your ligamentum. So you're going to have to be very thorough in terms of defining your edges and defining the plane before you remove the ligamentum off of the underlying dural sac to do your decompression. And when in doubt, I always try and confirm my plane with a curette or Penfield before I do any tissue removal. So I try and at least create some degree of plane. And this is where I will go to the Kerrison punch, and I'll use a smaller one if necessary. I'll use that small angle curette, and I will really try and create a plane to work in so that I can adequately decompress. And this is one of those situations where if you have a hard calcified ligament of flavum, you may want to do a more extensive decompression, proximal, distal, and lateral, so that you can make sure you're seeing and identifying your anatomy before you really go in to try and separate everything off of the underlying dura and the traversing nerves before you do your work. So once the ligament's gone, once the bony work has been done, and now you're doing your work, this is a discectomy picture. This is the suction retracting the dura, cephalatus to the picture's right, caudal to the picture's, cephalatus to the picture's left, and caudal to the picture's right. So that's the traversing nerve root. You can see the large piece of disc just under the nerve root. You want to be able to have enough room from your laminotomy procedure, and in fact, your laminectomy, if you're doing it same through a midline approach as well, you want to be able to visualize the lateral edge of the dural sac and the traversing nerve within the operative field, so that you can palpate and then gently retract it to be able to see what you need to see. This is classic for a microdiscectomy. If you're just doing a laminotomy or laminectomy for spinal stenosis, you don't necessarily have to do any work around the edge of the nerve, but you do want to make sure you're out there far enough so that you can see that traversing nerve and make sure you've got it adequately decompressed within the lateral recess, even in stenosis. I use blunt dissection in the epidural space always. I use a cottonoid oftentimes to kind of gently push in the epidural space lateral to where I think the neural structures are. It does sometimes make the plane more evident. I will use my Penfield, which I will turn the tip away from the nerve. I will use a small curette under the edge of the bone, all trying to create a plane between myself and the dura medially. You're going to have to control your bleeding. If you have bleeding in the epidural space, you cannot do any work safely. You just can't see. As it's been described to me, it's like working in an inkwell. You essentially you can't see a thing. So you've got to control the bleeding in order to adequately do the work you need to do. You want to try and be gentle with your nerve retraction for any type of neurologic manipulation, because you can create your own iatrogenic injuries. So frequent retraction breaks to minimize the risk of neuropraxia. And the key thing is, if you can't see it, please don't bite it, because the next thing you may have a ton of clear fluid in your field if you're not seeing what you're trying to bite or remove or pull on. So make sure you can see things before you do your work. So not only are we doing bony decompressions and neurologic decompressions within the interlaminar space, we also sometimes have to do other pathologies. So this is just a kind of a visualization of doing a far lateral decompression. Here we're now working out lateral to the exiting foramen. So our operative field is up in the picture A, where we're working at the pars. It kind of shows the dotted line in picture B shows the bony removal. So you're going to remove a part of the pars. You're going to remove a part of the lateral facet joint. You can approach this either through midline, or you can split the paraspinous muscles of the diagram at the bottom, which essentially shows the tubular approach. And this can be done through an open retractor as well. But your approach now is generally through the paraspinous muscles, although you can approach midline. I actually like to, when I do these, I like to visualize within my operative field the transverse process insertions of the level above and the level below where I'm working. I want to see where that TP is coming in, particularly at the inferior level. I use the transverse process junction to the pedicle as my reference point for getting to the disc space and adequately, safely decompressing the exiting nerve from inferior to superior. So that's why, I actually, when I'm doing these, I actually like to visualize the TP above and below because it really defines my exiting nerve root space. You actually have to remember that generally, as in picture C, the disc is going to be below the exiting nerve, but I have actually seen it where the disc material, if you're doing a far lateral disc herniation, the disc is actually has extruded up cephalad and now has pushed the nerve inferior, and it's literally right in your operative field. So this is one of the key things. You got to have good hemostasis, you got to have good visualization, and you got to have anatomic recognition of where you are. So what I will tell you is you oftentimes have to remove more bone inferiorly and medial. In other words, you're going to take more of that lateral facet joint, you're going to take more of that pars so that you can adequately get into the space below where the nerve is. I use the top of the inferior pedicle many times to adequately create the plane to get up underneath the neural element so I can lift it up so that I can make sure that I'm in the right spot and not essentially, coming down or cutting on the actual exiting nerve itself. So there are some nuances to doing this, and we can talk about it in more detail. This could be a topic all in and of itself in terms of the approach and the decompression, but this is just the far lateral. It's a variation of doing an interlaminar approach, but now you're working out with different anatomy and different landmarks. Then finally, one of the other things you can do is you can do essentially bilateral decompression or a laminectomy type operation through a unilateral laminotomy approach. This is oftentimes dependent on your approach corridor for getting into C. You got to make sure you can see the lamina that you're working from, but you're going to, the reality is you're going to end up taking more of the inferior spinous process on the side you come in from, so the ipsilateral side. So the diagram, the pencil diagram with the burr tip coming in, I think it's very adequate in terms of showing you you're going to come across. You really want to leave your ligamentum in place. It is protecting your underlying dura. You can see the burr coming across. I think it's best done for upper lumbar pathology, so L1-2, L2-3, sometimes L3-4, depending on how congenitally narrow the canal is. Sometimes this is better because you can preserve the contralateral facet a little bit better. So I think that if you try to do bilateral laminotomies in some patients above L3, you're oftentimes going to take a ton of that of the facet joints, and so you may create some iatrogenic instability. So this technique is actually fairly nice for doing upper level lumbar decompressions where you really want to get bilateral decompression. I will say that in my experience here, it's difficult to get underneath that lamina to undercut and remove that superior articular process on the opposite side. So you've got to have good visualization, you got to maintain good visualization, and then you've got to really continue to define the plane to get the decompression you want, particularly on the opposite side of the canal. And some people may be better at this than I am, so you can chime in if you have technique or pearls for doing that. But this is one technique you can do for decompression.
Hey, Jamie, I do a lot of bed manipulation with this.
Yeah.
So if you look at the last slide, if you look at the contralateral angle, it's really, really steep. Mm-hmm. And so you have to have your microscope at a really sharp angle to try to look down into that corridor as well, which can sometimes ergonomically be weird. But if you rotate the patient away from you, you're essentially changing the aperture of where you're working, and it becomes a lot more straight up and down. So I do a lot of bed and microscope manipulation when I work on that contralateral side.
I think for me, what I've learned is that the technique for me involves removing more of the spinous process from that ipsilateral approach side than I used to.
Sure, you got to take it up higher. Yeah, absolutely.
You got to kind of start at its inferior edge, and you got to kind of, because to get to that superior articular process on the opposite side, you're actually working almost in the interlaminar space, right? So you're not under the lamina anymore. You're actually you got to get above the ligament on the opposite side, and there's no
exactly.
Yeah. So it's an interesting, it takes some getting used to, and you're right. The angle, if you look at the upper, I'm gonna move my little thing here. If you look at this upper picture, I don't know if you guys can see my arrow, but the angle to get here, yes, you're right, Greg. You almost have to rotate the bed a little bit. But I like the diagram here where we've removed a ton of the spinous process to be able to get that angle. But it's steep. It's steep. but I've seen some really good, you know, the CT picture is really nice. And I've seen some other images and other studies and stuff that they looked at this, and they do a really nice job with their unilateral approach getting in. So some guys are really, really good at doing this. Let's see. Finally, same principles apply to cervical decompressions. I put in some diagrams and some bony work done for a keyhole foraminotomy. So you can do the same thing in the cervical spine. The principles remain the same. You want to identify your level, position your patient appropriately. A little bit of cervical flexion does help a little bit, but these are primarily for doing intraforaminal disc herniations or residual and or primary foraminal stenosis, where you do not need to do an anterior approach to get disc space height distraction and decompression from the anterior approach. And so you're in a different interlaminar space. And so you're basically going to remove enough of the lamina above and below to see the exiting foramen. I think the diagram up here on the right does a very nice job of showing the keyhole foraminotomy to get out far enough lateral without removing greater than 50% of that facet joint on the side. Same principles with the burr, getting good hemostasis. And it's just that the pathologies that we're doing this in the cervical spine are more limited. So the disc herniation, in my opinion, if it crosses towards the midline or is underneath the cord at all, I'm going to do that from the front. This is really for isolated pathologies where you have a very lateral soft disc or a foraminal stenosis that you're trying to do. And one of the key things on the cervical spine is the lower you go with patient positioning because of the shoulders, the harder it is to confirm your operative level. So you just have to be very diligent about getting enough images so that you know you're decompressing the right place. And then, so that's all I have for the technique here. I basically did put in a study where I did a little bit of looking at, I do a lot of bilateral decompressions now, trying to preserve the spinous process and interspinous ligament at the segments that I'm decompressing for stenosis. And there's a meta-analysis done back in 2015, looking at a bunch of studies at the effectiveness of posterior decompression techniques. And I think the only thing they found was a very slight trend towards decreased iatrogenic instability with bilateral laminotomy versus laminectomy, but not statistically significant in this meta-analysis. And the outcomes were roughly the same. So whether you did a full laminectomy or bilateral laminotomies, basically, depending on which study you look at, in other words, I don't think the data that's available for us to look at to say we're doing something better with a bilateral decompression via laminotomy, preserving more bony anatomy posteriorly is definitive, but the trend seems to suggest there are some theoretical benefits to the bilateral with stability preservation, potentially being the most significant in terms of preventing instability due to the surgeries we do. So that's all I got. Any questions from folks?
Yeah, on that note, Jamie, the other thing is that a lot of these studies don't have 5 or 10 year data,
right.
And I think what we're seeing is that there's preservation of the posterior tension band when you leave the spinous processes in place and their associated interspinous ligaments. If you remove all that, we see plenty of post-laminectomy kyphosis and things like that can happen as a result.
Yeah.
But that takes years and years and years to develop, right? So a meta-analysis is going to pick up on that because most of these patients are only followed for 6 months or a year.
Yeah, and the brief kind of review that I did looking at the topic, and there's several articles on bilateral decompression versus from a unilateral approach versus standard laminectomy. There's several studies there, but they're all short-term stuff. And so for the short-term outcomes, there's not a ton of difference in the outcomes within the studies. But I think you're right, Greg. I think the longer-term data, if we could do it and figure out a way to do it, would probably be helpful.
Okay. Yeah, I totally agree.
Questions?
Hey, Bruff.
Well, cool.
Yeah.
Hey, Jamie, it's Donnie B. I
Yeah.
just wanted to say I looked at a technology recently, and it's actually like an oscillating handpiece for the drill. So instead of it just, whipping around at 75,000 RPMs, it oscillates back and forth, similar to like a cast cutter. So instead of, having a concern of this thing, catching Dura or heating up to the extent the other one does, this doesn't. It was really nice. I actually went and I did a bunch of drilled around the Dura. And I think this thing's ultimately going to grow legs and run. But I think it's great for the training environment because I think, sometimes like putting in a pedicle screw, we can watch what the trainees are doing when we're doing these, decompressions through the tube or the tailor retractor. And now the bed is canted at an interesting angle, as Greg had pointed out. We oftentimes lose line of sight of what the trainees are doing, and there's a lot of apprehension that we have in sort of letting the trainees move in that direction. I think introducing this device will actually alleviate a lot of that concern because, we don't have to worry about, number one, the vacuum effect in soft tissues being sort of sucked into the drill. And then number two is the direct insult to the dura or neural elements because of, this thing whipping around at 75,000 RPMs. So keep your eyes out for it.
Yeah. Anything that the way I look at it, Don, anything that makes this particular operation or the technical part of this operation safer, I think is a great thing. Because, that's what this talks a little bit about, how I've evolved, how I do this to keep it as safe as possible. So for me, it's all bone work, all exposure, all the bone work's done. The ligament literally sits there until and I debulk it a little bit as I go through, but the ligament is sitting there until I'm ready to take it out, because that's the last step till I do my epidural work, right?
Yeah, exactly. Anyway, well, great. Thanks for putting that together.
No problem.